Good evening and welcome to the European Airway Management Society webinar about airway management in critically ill adults, the INTUBE study. We have with us some of the INTUBE study investigators. Two of them will be our dear speakers. First, I would like to introduce Professor Vincenzo Rossotto. He will be talking about INTUBE study findings. He's a consultant in anesthesia and intensive care at University Hospital San Gerardo, Monza, Italy, and he was also the lead investigator of the INTUBE study and INTUBE network. Olá, Vincenzo.
Hello, thank you and nice for the invitation. Thank you.
Thank you for joining us. And secondly, we will have Professor Sheila Nahan Mayatra. She's joining all the way from Mumbai, India, where she works at the Department of Anesthesia and Critical Care at Tata Memorial Hospital. She's the president of the All India Difficult Airway Association, chair of the Intensive and Critical Care Medicine Committee of the World Federation of Societies of Anesthesiology. She was also among the experts that are drafting the ASA Difficult Airway Management Guidelines and the PUMA Guidelines as well. And she's part of the editorial board of several journals that are very important. So good night, Sheila. Thank you for joining us.
Thank you very much. Thank you.
And also moderating this webinar, myself and Isabel Pereira, joining all the way from Portugal, and joining from Argentina, Dr. Paula Chiesa. Olá, Paula. We are EMS Board of Directors members, and last but not least, Massimiliano Sorbello, joining all the way from Italy, our EMS president and also one of the INTUBE study investigators. Hi, Max.
Hi, everyone, and happy to see you all here.
Fantastic.
Hi, Anna. Thank you very much for your introduction. We are happy to host this webinar. EMS wishes to make them as interactive as possible. For that, I will ask you, all the participants who are joining and have joined us all over the world, to share all the doubts that may come across your mind in the Q&A box, the one at the right in the bottom, so it's easy for us to collect them and to read them to the great speakers we have here with us today. I emphasize in this box, please, it's a lot easier than in the chat. And please, would you all turn off your microphones so that we can listen better. Well, this evening, we are going to talk about the critically ill patients and particularly airway management and the complications that arise during intubation of the critically ill patients. It's often said that they show complications, but it would be interesting to know exactly which more often, and finally, what we can do as clinicians to prevent them. We will start by sending the first poll to the audience. Can we see it, please? In your opinion, based on your judgment and your usual clinical practice, which is the most frequent complication during intubation of a critically ill patient? Severe desaturation, difficult intubation, that means requiring more than 2 attempts, aspiration of gastric contents, or hemodynamic instability. Please pick up one choice, one answer, and press send. And in a while, we'll have Vincenzo to explain this to us.
think that we might have the poll results in about 1 minute. So it will be interesting to see what the audience thinks, right?
Well, Vincenzo can start while we collect the results.
Fantastic.
Please, here we have the results. Okay, so 52% of the participants pointed that hemodynamic instability is the principal complication of critical patients undergoing intubation, sorry. It seems the audience has read the INTUBE study, I think. It's a wonderful paper, highly readable. And we have also sent it to the members, it shows. Well, Vincenzo, now to you.
Yeah. Okay, so thank you again for the invitation to this nice webinar. It is a really pleasure and honor to discuss the results of INTUBE study with all of you. I have no conflict of interest for my talk, and the rationale behind INTUBE study is that tracheal intubation is among the most commonly performed procedure in critically ill patients. And this is also associated with a high risk of adverse events, such as hemodynamic instability, cardiac arrest, and severe desaturation. However, this complication and the information of this complication until now were available only from single center studies or from national level studies, and no large prospective international data on this topic were available before the INTUBE study. So that was the reason to launch this type of study. This is probably the only one international study which is instead of a national level study, which is the National Audit Project 4, which has been published 10 years ago. And for the first time, the study probably highlighted how airway management in critical ill patients is associated with a high burden of morbidity and mortality. Because if we look at the numbers, 61% of patients in the ICU had severe consequences from airway management. As you can see here, 61% of patients with airway complication died or had severe brain damage. And these are really impressive numbers, both from the perspective of the high frequencies of this complication, but also from the high morbidity and mortality of these numbers. So this was the strong rationale behind the need to launch an international study like INTUBE study, which is simply a snapshot of what happens around the globe in order to identify which complications are the most common and which are the incidents of this complication in order to identify also research priorities.
And so, Vincenzo, how did you carry out this huge study from 29 countries?
Yes, thank you. Yes, this is an international observational study that we launched in October 2018, and we completed at the end of July 2019, so before the COVID-19 pandemic. And we enrolled 197 sites across all continents around the globe. As you can see here from this map, this is an important value of INTUBE study, because for the first time we have a collection of information not only from US or Europe, which are the main countries and the main places which have provided important information on airway management, but also from other countries such as India, or also many countries from Europe and even from Africa, So this is a really truly representation of what happens not only in big university centers, but also from peripheral centers around the globe. And this is possible. This was possible thanks to also to the support of many scientific societies, including the European Airway Management Society, and I am grateful for this support. They providing the endorsement to the study, and they contributed a lot for this success. The patients enrolled in the INTUBE study were adult critically ill patients undergoing in-hospital intubation. And this is also another important information that we collected. The intubation not only in the ICU, but also in the emergency department and in general wards. And we excluded those patients intubated before hospital admission. Those patients receiving intubation only to receive general anesthesia, so not critically ill. And we excluded also patients intubated for cardiopulmonary resuscitation during cardiac arrest. This was the primary outcome of the study. We decided to include a composite outcome. So we collected at least one of these information: severe hypoxemia, defined as an SpO2 below 80%, cardiac arrest, and cardiovascular instability, which we define as a systolic blood pressure below 65 or at least one time, or a systolic blood pressure below 19 for more than 30 minutes, or the need for a vasopressor or the increase of vasopressor after intubation, or also the need for a fluid bolus of more than 15 ml per kilo in order to keep and maintain the target blood pressure for that patient. And we also collected different secondary outcomes, such as ICU mortality, the incidence of cardiac arrhythmias, the difficulty intubation, which was defined as the need for more than 2 laryngoscopic attempts, or the incidence of pulmonary aspiration or airway injuries in general.
And so, Vincenzo, I am curious about the characteristics of the patients who you actually got to enroll to the study, but also about the operators who performed the intubations. Can you tell us, please?
Yes, thank you for this question. So we enrolled at the end almost 3,000 patients around the globe, and we follow up all these patients, almost all these patients, until ICU discharge. And these are the demographic and clinical characteristics of our patients. We had a median age of 63, SOFA score of 7, and PF ratio, or SpO2 to FeO2 ratio of 165. So we had a quite hypoxic population at the beginning. While if we look instead of on the hemodynamic parameters, as you can see here, for example, the mean systolic blood pressure, we noticed that the baseline hemodynamics parameters were quite good at the beginning. And the location of intubation was the ICU in most cases, as you can see here. Almost 70% of patients were intubated in the ICU, and respiratory failure was the leading reason for intubation in approximately 50% of patients. Concerning the operator characteristics, as you can see here, we have residents as the operators performing the first attempt of intubation in most cases in approximately half % of patients, and this is also because we have approximately 70% of academic hospitals in our trial. But the field of training of the operator is the anesthesia in again in approximately half % of patients. And this is also another important information, the number of operators on the field, because we know that the number of operators is relevant in order to manage airway in critically patients. But from INTUBE study, we know now that in approximately 50% of patients, only one operator able to trained to perform the intubation was present at the moment of intubation.
And so now let's move to the results, shall we?
Yeah. So the primary outcome of this study is this one. We know that 45% of patients had at least one major peri-intubation event. That is a really impressive number. But also interestingly to know that the first major peri-intubation event was cardiovascular instability in approximately 43% of patients, followed by the severe hypoxemia in 9% of patients and cardiac arrest in 3% of patients. And we also have interesting findings also from secondary outcomes, because we have approximately 6% of esophageal intubation, approximately 5% of difficult intubation in our cohort, and approximately 4% of intubation of aspiration of gastric contents. Another important information that we have from INTUBE study is that if you fail the first attempt of intubation, then the risk of complication increases. This is already known from previous study, but we confirmed this finding in a large prospective cohort. So from the second attempt of intubation, the risk of complication increases, and this is true for the overall composite outcome, but also from the single outcome of cardiac arrest and of severe hypoxemia. And if we look at the number of first pass success here in the INTUBE study, we have approximately 80% of first pass success. So this is also another important information to collect in real life today. And another important information in this one, that if a patient during airway management suffer from one adverse event, as you can see here from the survival curves in black, we have patients with major adverse events. There is an increased risk of dying, both during the ICU stay, but also at 28 days. And this is true again for the overall outcomes, so the composite outcome, but also from the single outcome of cardiovascular instability and cardiac arrest. And interestingly, this was not observed for the outcome of severe hypoxemia. So this is simply to say that these outcomes also, even if probably in some patients are only transient, may be really meaningful from the final outcome of our patient. For sure, this is an observational study and many confounders may play a role. But if we perform an adjustment for baseline characteristics of our patients, the risk of 28-day mortality was observed even after baseline characteristic correction. So we had an adjusted 28-day mortality of 1.44 as odds ratio. So just to say that these events may truly have a role on the patient outcome. We also identified variables associated with adverse events. And in order to probably identify how we can improve our procedure and if there are variables that may be modified before the intubation in order to reduce these risks. So we have a number of unmodifiable patients-related variables, such as older age, the presence of an heart failure, or hematologic malignancies that are baseline patient characteristics that are significantly associated with a higher risk of complications. But also we have a number of variables that may be modified before intubation, such as the hemodynamic parameters And we will discuss this issue afterwards. And we also have an interesting finding here, which probably deserves further discussion, that video laryngoscopy seems to be associated with a higher risk of complication, along as the use of fluid bolus before tracheal intubation. As you can see here, the hypoxic patient is also at higher risk of overall complication. But if we instead get the first pass success as previously described, we reduce the amount of and the risk of peri-intubation adverse events, and this is probably what we should work on more. We also identified which factors are associated with the first pass intubation failure or success. And as you can see here, the well-known variable, anatomical variable that are associated with the risk of difficult anatomical airways are all involved. As you can see here, a higher Mallampati score, reduced mouth opening, neck stiffness, presence of bird, the risk of aspiration, the past surgery or radiotherapy of the neck are also significant risk factors for failing the first attempt of intubation. But we also have interesting findings here. The use of video laryngoscopy, as you can see here from the odds ratio, is instead associated with a higher possibility of first pass success, but also important information from the operator characteristics, because being a staff physician or a consultant instead of being on training or a resident is associated with a higher possibility to get the success at the first attempt of intubation. And another important finding is this one, that the field of training, the anesthesia training, is associated with a higher success compared to other training that we collected during the study. In a large international study like the INTUBE study, we have many operators involved in airway management, such as pneumologists or internal medicine clinicians and so on. But probably having a strong airway training, such as those with an anesthesia background, probably have an important role in order to get the first pass success and indirectly to reduce the risk of adverse events. Another important finding and value from INTUBE studies also from the collection of the description of the procedure, because we collected details on the procedure from drugs to the pre-oxygenation methods and so on. And this is another important finding also to identify priority of research and take a snapshot of what happens in real life. This is, I point out here the most interesting findings. For example, the use of a protocol was applied in only half a procedure in real life. So in the other half of patients, the protocol was not applied or was not in place. And other findings also from the pre-oxygenation methods, as you can see here. The leading pre-oxygenation method today is still the back valve mask, while other interventions, such as the apneic oxygenation methods here, is rarely applied in real life. And this is interesting to observe. So the pre-oxygenation methods, back valve mask, the leading pre-oxygenation method today, while other methods such as non-invasive ventilation or the high-flow nasal cannula or the CPAP are seldom used in real life. And if we remember the patient characteristics of our study, it is interesting to observe that our cohort was quite hypoxic, and the reason for intubation was respiratory failure in most cases. But despite this, back valve mask is still the leading method that operators today apply. Other important finding, the induction agent. The propofol is the leading agent that used in a general population of ICU patients and critically patients in general. This is a interesting findings too that probably will be discussed later on. And other interesting findings, the use of video laryngoscopy is applied in only 17% of patients, and in most cases an anatomical difficulty was present before the laryngoscopic attempt. So the video laryngoscopy is not systematically used in critically patients today. It is seldom used and only when an anatomical difficulty is present. But what is probably the most striking observation from INTUBE study concerning the procedure come from the observation of the monitoring systems, because we observed that in only 25% of patients, the wave of capnography was applied. This is a really impressive results. Also because if we look at the place where intubation was performed, only 40% of procedure in the ICU had a capnography in place, so a higher use, but still well below what we consider a standard. And in the emergency department, this number is even lower, 20% of patients, and in the wards, the capnography is almost not present if we look at these numbers. And this is impressive also because we know from the National Audit Project, this is the study that I showed you at the beginning, we know that in most cases of Airway disasters that those authors reported, the lack of capnography or the misinterpretation of capnography had a major contribution to severe consequences, including that of patients. And this is really interesting to observe that almost 10 years after that observation, the practice seems not to be influenced by the current evidence. Thank you.
Thank you, Vincenzo. Great findings. Now I would like to ask the audience, in view of your results, please can you send the second poll? Which is the highest priority intervention to improve outcomes of critically ill patients undergoing intubation? I mean, what can we do to improve the outcome? Identification of the best pre-oxygenation strategy, systematic adoption of video laryngoscopy, identification of the best method for peri-intubation hemodynamic optimization, or systematic adoption of awake intubation. What do you think? And what would you do after listening to this webinar? Please, you need to choose only one.
Oh, while we wait for the results of the poll, do we have time to answer for a question from the audience?
Yes, sure, Max. I was going to ask you to read the first questions.
Great. We have two questions. One, I think Vincenzo can provide an answer, even because of another study which came out on JAMA almost together with the INTUBE. Anyway, there's a colleague from Peru who's asking some more details about pre-oxygenation with helmet. Which flow or PEEP you advise for pre-oxygenation? And then I have a question maybe for the whole panel. Our friend Hans Sweeting from the Netherlands asks us, or asks himself, why CO2 is still so underused despite we know all of this.
Thank you for these questions. Well, concerning the helmet pre-oxygenation, this is an interesting question also because today with the COVID-19 pandemic, we currently use the helmet CPAP as pre-oxygenation methods. because there is evidence now that probably the helmet CPAP is quite safe in order to reduce contamination of the environment. So this is just to say that we currently use this method almost for all patients intubated due to respiratory failure with COVID-19. We normally applied approximately 8 centimeters of water of PEEP, considering that in that case, we use a filter, the EPA filter, which has been shown that to provide also an expiratory resistance of approximately 4 centimeters of water, which depend also on the flow of the gas that we use for the helmet. So we use for sure approximately 8 centimeters of water with an EPA filter. Concerning the capnography use, it's probably I don't know, probably this is probably an interesting finding, because you know that capnography is costless, so probably it is available, and despite its costless and availability, probably the clinicians finds that feel confident that it is not necessary during this real life procedure. This is an interesting finding that has been also observed in other settings, such as, for example, the neuromuscular blocking agent use. We know there are many editorials, for example, of the lack of use of neuromuscular monitoring, despite the availability of neuromuscular monitoring and the costless of that device. This is probably a really interesting finding to further explore the psychology behind this finding, but I have no explanation for this. What do you think, Max?
Well, I think it's a series of things. I believe that it's different psychological approach in the ICU, maybe the team or whatever. We should work on the team and awareness of this. I believe that it's simply given less importance to CO2 because you're more concerned about other issues. But you're right, we need to explore all of this. We have many questions, but there's just 2 of them. So many points about use of videolaryngoscope, CO2. This we may discuss also after Sheila's lecture. But meantime, I have a nice question from our US friend, George Kovacs, who was wondering whether some of the result of the INTUBE study, I mean, the main result was the hemodynamic effect of intubation. He was wondering whether it may depend on extensive use of propofol and opiates. So if maybe these results are linked to the agents used for intubation rather than to the, general setting per se.
Well, it may be true, although in the overall analysis, the primary analysis, this was not observed. We included propofol among the variables in the multivariate model, and this was not, so the agent was not significantly associated with the overall outcome. For sure, we are now working on the hemodynamic sub-study of the INTUBE, and we are now performing a causal inferential model in order to investigate whether fluids, propofol, have and the use of vasopressor may have an impact on the incidence of this high hemodynamics complication rate. For sure, this may play a role in different patients, and this is also interesting to observe. And probably we may suggest to avoid propofol in critically patients, along with identifying methods to improve hemodynamics before intubation.
Yes, and this is other point raised by the audience. I believe, I mean, I know George, I believe his question was rather provocative, and there were a couple of observations from other attendees. I believe many of them, they are suggesting or underlining importance of the team so that they can share the work. One who is in care of the airway, one who is in care of hemodynamics, which may include monitoring, taking a look at monitors, administering bolus or whatever. I think we are lacking evidence on this. We need to work on this. It's probably one of the most important issues we need to work. And there is also some interesting points. I mean, but this we may discuss later, Paula, probably. There are many questions about the best pre-oxygenation strategy. We may give a whole webinar on this, but I don't know, Paula, shall we move to the next section? Then we try to answer some more questions.
Yes, please, let's move on. Otherwise, we'll be short of time.
Okay.
Anna, can you please introduce Sheila?
Of course. So basically, Sheila doesn't need any introduction. She's a very well-known speaker. But before we start the INTUBE study, the lessons that we learned and the way forward, we have a challenge to our audience. So we would like to start a poll, our third poll, which is basically, in your opinion, our participants' opinion, what are the factors that make airway management a high-risk procedure in critically ill patients, thereby increasing the risk of complications? So, A, is it the critical illness of the patient? B, the complex ICU environment? C, the variable level of training and skills among the airway operators? D, all the above, or the last option, higher anatomical difficulty in critical ill patients than in comparing to the more stable OR patients. So please take a minute, whatever you feel like. What are the factors that make airway management a high-risk procedure in critical ill patients? So please start your vote. So Sheila, I'm really looking forward to these poll results. I think people will get pretty much enlightened during your lecture, right?
I hope so, yeah.
They will. I am sure of it. So please remember, all your questions you want to address our speakers, please keep on posting them in the Q&A button below. So we'll try to address all of them. It's a one opportunity. So please, poll results.
Okay, that's very interesting.
It is very interesting. So all the above, critical illness, the ICU environment, and the level of training and skills among operators. And now our fourth poll to our audience as well. What is a physiological difficult airway? So in a shorter time, we'll start that poll. So what is a physiologically difficult airway? Is it an altered physiological of the patients that makes tracheal intubation difficult? It's the patient physiology altered by induction agents used for airway management. Is it severe physiological derangement in the patient that increase the risk of cardiovascular collapse and other complications during airway management? All the above or none the above. So please select the option. What is a physiologically difficult airway? Please cast in your votes. 1 minute. And again, the questions to our panel, please keep on posting them on Q&A section.
Thank you, Anna, for that question. I think my talk will answer some of these 4 questions that have been asked.
Yeah, I think we'll be very enlightened regarding what our audience feels. And we have a pretty broad audience coming from all over the world. And thank you for joining us to our EMS webinar. this one about the fantastic INTUBE study. So, poll results, please. All the above. And see, a third thinks severe physiological derangement in the patient that increase the risk of cardiovascular collapse. Okay, so we think we are going to address all these questions during your lecture. Please, Sheila, the floor is yours.
Okay, thank you so much, Anna. And first of all, hello, friends, and greetings from India. And at the outset, I'd like to thank the European Airway Management Society for giving me the opportunity to speak at your meeting, and also to Professor Vincenzo Rusotto for giving me the opportunity to participate and play a major role in the INTUBE study. So Vincenzo has already given details about the INTUBE study. And what I'm going to do is take this forward and speak about the lessons that we've learned and the way forward, how we could take it from here. So I'd like to declare that I have no conflict of interest. Now, if you look at the complications of tracheal intubation in critically ill patients, now if you look at all the series that have been published so far, and as Vincenzo said, they've been small series, but people have looked at complications in critically ill patients during tracheal intubation, and you can see that they are definitely much higher than what you see in the operating room, whether it's hypotension, hypoxia, etc. And what INTUBE study has really done is looked at this globally in a large number of patients, close to 3,000 patients, and kind of proved this is actually true. The overall complication rate of having at least one major complication was as high as 45%. So this is really serious. You know, you have a very high complication rate, much higher than what you see in the operating room. So definitely tracheal intubation in the intensive care unit is in critically ill patients is a high risk procedure. Now I'm an anesthesiologist, but I work as an intensivist, but I do spend some time in the operating room. So I have the unique opportunity of comparing airway management in the critically ill patients and airway management in the operating room in the same period of time. And in my mind, there are three fundamental differences between airway management in the critically ill and in the operating room. First is the ICU environment related factors. I'm sure you all appreciate that the environment is completely different when you're doing a tracheal intubation in the ICU. The second are the patient factors. The patients are completely different. And the third is the operator factors. Now let's go to the ICU environmental related factors. And this is just a picture of me doing an awake fiber optic intubation in the operating room. Now, look at the space around the operating room table. I have my resident here to help me. I have another assistant who's helping me. I have every tool in my armamentarium. I even have a bunch of surgeons around who could help me if things could go wrong. Very controlled conditions, very stable patient. And look at myself doing a tracheal intubation in the intensive care unit. Now, this is a patient in septic shock who's come in. So I not only have to handle his airway, but I also have to stabilize this patient from a hemodynamic standpoint. And I only have a male nurse to assist me because my resident is resuscitating another patient. Now, look at the struggle to just get to the head end of the patient in an intensive care unit. It's not easy, not like in the operating room. There's so much clutter around. I have my crash cart, I have my ultrasound machine, the ventilator, monitor, a whole lot of things around. It's a really complex environment. I don't have every tool in my armamentarium as I would have in the operating room. So the ICU environment itself is quite a complex area to do tracheal intubation as compared to the controlled conditions in the operating room. And the second point I said is the operator factors. And we have enough evidence today to show that intubation skills and supervision make a difference to the outcome, especially supervised by a senior or supervision by an attending anesthesiologist, formal training in anesthesia, and also juniors routinely trained and supervised. So training and skills acquired in airway management make a difference to the outcome. And the third most important is the patient factors. And I'm sure you all appreciate that critically ill patients are not the same as the stable, fasted patients in the operating room who come for airway management. And why is that so? Most of these patients who are critically ill have an imbalance between oxygen delivery and consumption. And there are various factors in critical illness that result in decreased delivery because of low cardiac output, anemia, lung disease, low FRC. and this can all compromise the delivery. In addition to this, you can have increased consumption because of fever, sepsis, tachypnea. So you start with a patient who's critically ill, who has an imbalance between oxygen delivery and consumption, and this further increases the incidence of complications in these patients and the risk of complications. And this is what we, when we say a physiologically difficult airway, and I'm very grateful to my friend, Professor John Sackers from United States, who actually highlighted this term, also coined this term, I think, and made this very important during airway management, because people always talk about anatomical difficulty, and we've been conventionally trained to talk about difficult airway means anatomically difficulty, but there's also the physiologically difficult airway. And what does that mean? It means that the physiologically difficult airway, we can define this as one in which when there is severe physiological derangements, these place the patient at an increased risk of cardiovascular collapse and other complications, and even death during tracheal intubation and the transition to positive pressure ventilation. So not only do we have to focus on anatomical difficulty, which we've been conventionally trained to do, but also look at the physiological difficulty in these patients. So when we secure the airway of the patient, what we conventionally do is pre-oxygenate them, induce anesthesia, induce apnea with a muscle relaxant, give them mask ventilation, laryngoscopy, intubation, and positive pressure ventilation. Now, in critically ill patients, these patients have a physiologically difficult airway. It's a critical illness. It could be, metabolic acidosis, right ventricular failure. It could be acute circulatory failure. So all this constitutes a physiological difficult airway, and this increases the risk of hypoxia and hypotension, and increases the morbidity and mortality. And in addition to this physiologically difficult airway, if you also have an anatomically difficult airway, this can further make the situation really very complicated. And this actually prompted us to write this review almost 10 years ago with my colleagues. And I gave it a very provocative title: Tracheal Intubation in ICU, is it life-saving or life-threatening? So this procedure, as we consider as a life-saving procedure, seeing the results of the INTUBE study and the high rate of complications, can actually be a life-threatening procedure if you don't take appropriate measures to try to avoid the complications. Now, very interesting from the INTUBE study, if you look at the most common indications for tracheal intubation, they were respiratory failure, which was 52% of the patients needed tracheal intubation for this reason. And the second one was neurological impairment. But if you look at the primary outcome, of course, you see the complication rates were very high, close to 45%. But if you look at the complications, it was the hemodynamic instability, which was 42%. And if you look at severe hypoxia, it was only 9.3%. So there's a kind of, the indications were respiratory failure, but the complication that was higher was hemodynamic instability.
So, and Sheila, my question is, and also one of the questions from the audience is, although what could be the reason why cardiovascular instability was higher than severe hypoxia during tracheal intubation in the critically ill patients?
Very interesting question, Anna. We always knew complications in the critically ill were high, but what INTUBE study revealed was it's actually the cardiovascular instability that's higher and what we need to focus on. And I'm sure Vincenzo will agree that this came as a real surprise finding to us. And perhaps the reason is, if you just ask someone offhand which complication would be the highest, they would probably tell you hypoxia. Because this has been ingrained with us, airway management, delayed intubation, difficult intubation, the patient will get hypoxic. And this comes from a background of anesthesia training where we think like this. But often, and so the focus has always been to improve, develop strategies where we could improve, the peri-intubation oxygenation. Though INTUBE study didn't show that this has really achieved the levels that we would have desired. But definitely our focus has been largely on pre-oxygenate well, apneic intubation, peri-intubation, avoid hypoxia, that's ingrained in us. So I think over time, we've become better at this. We've become very conscious and aware of this. But the one thing that we haven't recognized is that it is the hemodynamic instability and the incidence of this that is higher. And perhaps one of the biggest messages of the INTUBE study is that this is the area we really need to focus on when we talk about improving outcomes in critically ill patients. Thank you, Anna, for that question. And not only that, Vincenzo's already shown you that not only are the complications high, but the INTUBE study is the first study that has shown that these transient complications that occur during tracheal intubation, which perhaps could be managed with vasopressors and oxygen, actually impact outcome. So there was an increased 28-day mortality when we looked at overall complications, when we looked at cardiovascular, when we looked at cardiac arrest, and even when we looked at the patients who developed hypoxia. So this is the first study that actually shows that this transient effects that occur during tracheal intubation can actually impact 28-day mortality. And I think if that's the case, then avoiding these complications and adopting various strategies to reduce this complication is really paramount. So if you look at strategies that we could adopt to limit these complications, we look at the things results of the INTUBE study, and definitely there have been questions on this: team preparations, addressing human factor concerns, planning, preparation. While often I agree that, it might be an emergency and you may not have time to do all these things very optimally, but this is something we should focus on. Peri-intubation, oxygenation, and of course, seeing the results of the INTUBE study, strategies to avoid this hypotension. We need to limit the attempts at intubation. And to limit the attempts at intubation, we need to have strategies to improve first pass intubation success, and definitely use capnography to make sure the tube is in the trachea and not in the esophagus. So these are some of the strategies that we could use to limit these complications. So let's come to avoiding hypoxia. And as I've mentioned, over time, we've become very conscious about this complication. Hypoxia can occur. These are difficult intubations. Let's avoid hypoxia. So we've become, by and large, quite good at the peri-intubation strategies, not only pre-oxygenation, but now we also give our patients apneic oxygenation, post-extubation, high-flow nasal cannula oxygen, or NIV, or helmet. So we've become pretty good at that. And this is a recent review that we published in Intensive Care Medicine, along with Audrey de Jong and Jonathan Casey. And this cartoon very beautifully summarizes the non-invasive respiratory support that you could give to a patient who presents to the critically ill patients. And just to summarize, when a patient comes to you with acute hypoxemic respiratory failure, definitely high-flow nasal cannula oxygen and conventional is superior to conventional oxygen therapy. Whether high-flow nasal cannula oxygen is better than non-invasive ventilation. In this period, the Florali-1 study from JP Frat from France, a multi-center study, didn't really show a difference in the primary outcome. Nevertheless, there was a decreased 90-day mortality in patients who receive high-flow nasal cannula oxygen. So this still needs to be studied further, but definitely high-flow nasal cannula oxygen and NIV are superior to just using conventional oxygen therapy. As far as tracheal intubation is concerned, we try to do rapid sequence intubation as far as possible because of the perceived risk of aspiration, and many of these patients may not be fasted, and there's also the gastroparesis of critical illness. Now, in terms of pre-oxygenation, these critically ill patients who are at a high risk, the Florali-2 study has done a head-on comparison with non-invasive ventilation and high-flow nasal cannula oxygen. And again, there was no difference in the primary outcome of, there was no difference. However, in the subgroup of patients with PaO2, FiO2 ratio less than 200, non-invasive ventilation was superior to high-flow nasal cannula oxygen when used for pre-oxygenation. And we also know the benefits of apneic oxygenation, continuing oxygenation during attempts at intubation. And Jonathan Casey's study in NEGM has shown us that even while we're performing mask ventilation, we could give gentle, tracheal intubation, RSI, we could give gentle mask ventilation to avoid the complications like hypoxia. And post-extubation, of course, in high-risk patient, you could extubate them to non-invasive ventilation or high-flow nasal cannula oxygen. This is just a summary of how we could use the peri-intubation oxygenation and non-invasive respiratory support in these patients. But coming to the most important one is avoiding hypotension, because the INTUBE study has shown us that the incidence of hypotension is really pretty high. And I'll draw your attention to this landmark paper in Lancet. And this was a practice-changing paper. And this compared etomidate and ketamine for rapid sequence intubation. So, recognizing that the intubation in critically ill patients is associated with hypotension, cardiovascular collapse, we needed to use a drug that caused less cardiovascular instability. And this was a large series. And this head-on comparison showed no difference in the intubation condition or SOFA scores, but more patients had adrenal insufficiency with etomidate. And a more recent study, and this comes from the emergency department, close to 1,000 patients, and they found that patients who were induced with ketamine had more ICU-free days, ventilator-free days, and hospital mortality similar to those patients induced with etomidate. So a drug that's not so much used in the operating room, ketamine, has really found its way into the intensive care unit. And unless contraindicated today, we should be using etomidate or ketamine for tracheal intubation in these critically ill patients, considering the high incidence of hypotension. And as Vincenzo's shown us, interestingly, though we know about ketamine and etomidate, the most preferred agent was propofol. So this is
Indeed. But that was quite surprising what you find in your study, that propofol was the main drug used as an induction agent to the critically ill patient. So it looks like there's some sort of aversion to ketamine, and there's lots of proofs out there. So what are your comments on this, Sheila?
Right. So this is, and one of the people from the audience also asked this question. Now, if you look at the drug ketamine, this is something that's found its way out of the anesthesia practice. It's not a great drug. We have better agents available today for anesthesia, and people don't like to use ketamine. And this may be one of the reasons why anesthesiologists don't prefer this drug. On the other hand, I can say that these patients have, there's also the recognition that these patients can have cardiovascular collapse after intubation. Now, when these patients come to you, they come for tracheal intubation. There's a lot of sympathetic drive. They're tachycardic. Their blood pressures are high. And this gives you a false sense of security. And you think, okay, everything's fine. I can use ketamine because you like that agent. It gives you very good intubating conditions. Not ketamine, sorry, propofol. So people prefer to use propofol. But what happens in critically ill patients? They may be in septic shock. They may be hypovolemic. And they are already intravascularly depleted. And once you give propofol, there can be precipitous fall in blood pressure. And this is what leads to the arrhythmias and the cardiac arrest. And this happens only after the agent is given, and you don't really see it before often. And this may be one of the reasons why people, tend to give it. Also the background of anesthesia where they like to use propofol. But definitely, though there was no difference in the multivariate analysis, there was a trend towards more adverse events when propofol was used. So this is definitely something, when we look at the sub-analysis of hemodynamic complications, is something we will definitely look at. And perhaps, there may be a role to avoid using propofol in critically ill patients and prefer to use ketamine or etomidate unless contraindicated. Thank you, Anna, for that question. And then coming to the more important question, and this is the study, the prospect study from Vanderbilt University. And if you know about the intubation bundle from Professor Samir Jaber, he's actually studied, preloading with 500 mL of saline before doing tracheal intubation, anticipating that these patients had a high risk of cardiovascular collapse following intubation. And that is what a lot of intensive care units practice across the globe. They give a fluid bolus. And this study from JANS actually there was a randomized controlled trial, 337 critically ill patients. And what they did is they randomized one group of patients to 500 mils of crystalloid solution or no fluid bolus before tracheal intubation. And their primary outcome was cardiovascular collapse. And very interesting, they actually found that the administration of intravascular fluid, intravenous fluid, did not decrease the incidence of cardiovascular collapse compared with no fluid bolus in this trial. So this was a really surprise finding. There was no difference. And in fact, the INTUBE study has shown worse outcomes in patients who received fluid bolus. So this is very interesting because INTUBE study shows that hypotension is the most important complication. It's the highest incidences with cardiovascular collapse and hypotension. Our conventional practice of fluid bolus has probably, has shown no difference. The INTUBE study, there's a trend towards harm by giving fluid bolus, but we have high incidence of hypotension, so we have to try to prevent this. So perhaps there is a role for the early administration of vasopressors in this high-risk group of patients. Of course, this has to be studied prospectively, but if you can't give fluids and fluids are harmful, then perhaps this may be the way forward and something that needs to be studied. We need to limit the attempts at intubation. And this is one of the earlier studies by Mott, close to 1,000 patients. And this has clearly shown that if you have more than 2 attempts at intubation in critically ill patients, you look at the risk ratio for any of these complications is much higher when you have more than 2 attempts at intubation. And this is not the situation in the operating room. And the very, very important message from this is in critically ill patients, you limit the attempts to 2. And subsequently, there have been several studies, I won't go into details of this, which has clearly shown that more than 2 attempts or sometimes even 1 attempt may lead to increased complications in critically ill patients. And the INTUBE study, it's interesting because the first pass success rate, if you look at it, is only 79%, which is pretty low. Okay, if, as an anesthesiologist in the operating room, if you look at such a low first pass success rate, you know, it would be a little surprising, but the success rate was quite low. And not 2 attempts, but more than 1 attempt at tracheal intubation, even between 1 and 2 attempts, actually there was a difference in the overall complications in the instance of cardiac arrest and severe, hypoxia. And the important message from this is we need to optimize our first pass success rate. And though only 17% of the patients visual laryngoscopy was used, we know that visual laryngoscopy is an important tool to improve first pass success rate. Other tools could be used like a bougie. And this was the study that was published in JAMA in 2018, where they compared the use of a bougie with an endotracheal tube versus using a stylet on first attempt intubation success. And this was, of course, in patients who had at least 1 difficult airway characteristics and underwent emergency intubation. And very interesting findings that they found that the outcome was much better. This was their primary outcome, was much better in patients in whom a bougie had been used compared to when a bougie and a tube was used with a stylet. Of course, this study was criticized. It was a single study center study, and it was also a study which center which was very experienced with the use of bougie. Nevertheless, it gives you some confidence that if you are skilled in the use of bougie, perhaps there is a role for using the systematic use of a bougie rather than wait, do an intubation, attempt an intubation, and then if you fail, go ahead with a bougie. And more recently, we have the stiletto trial that has just been published a few days ago. And this, I would say, is one of the largest randomized controlled trials in airway management. And this comes from Professor Samir Jaber from France. And they did a very simple, very interesting study. They compared 2 groups. One was just going straight away with a endotracheal tube for intubation. And in the other group, they put a stylet in the endotracheal tube. And so it was endotracheal tube versus endotracheal tube plus stylet. And this was a multicentric study done in France, randomized controlled trial, very interesting findings. They found that their primary endpoint was intubation, first pass intubation success, and it was much better when a tracheal tube has been used with a stylet and without any increased incidence in complications. And this is really interesting. Someone might argue that, oh, you use the stylet, as in your first attempt. I use a stylet all the time. I use a stylet all the time for all my intubations, but stylet are associated with traumatic complications. And not everybody uses a stylet during their first attempt. So this is an important study because it's the first time that this has been prospectively studied in a randomized controlled trial and with the use of direct laryngoscopy. So perhaps these tools along with video laryngoscopy can improve first pass success because we've shown a difference between first attempt and second attempt also makes a difference to overall complications, cardiac arrest, and even hypoxia. And if you have an esophageal intubation in the operating room, it can be quite, forgiving. Sometimes, you have junior trainees who put the tube in the esophagus, you take it out, you mass ventilate, and you do laryngoscopy again. But in the critically ill patients, even a single episode can lead to 51% hypoxemia. If you look at any of these complications in patients who had esophageal intubations and no esophageal intubations, you can see all these complications are much higher in these patients. And this is why it's very, very important to make sure that your tube is in the right place. And the important message from this is to use capnography to diagnose esophageal intubations. Now, interestingly, from the INTUBE study, and Vincenzo's already alluded to this, video laryngoscopy use was only 17%. That's really, really low. And this wasn't in the developing world. It was across the globe, even in centers where video laryngoscope was readily available. It was not the preferred technique, and direct laryngoscopy was used much more. And if you look at stylet use, it's about 77%, and bougie was used in 25% of the patients. And as Vincenzo was already alluded to, auscultation was the primary method of identifying whether the tube was in the right place, and only 25% of the patients received capnography to confirm tracheal intubation. So a very, very important message from Vincenzo's study is that use capnography even 10 years after the National Audit Project, which has clearly shown that not using capnography resulted in increased mortality and morbidity in patients undergoing tracheal intubation in the subgroup of patients from the ICU. Even today, only 25% of the patients actually of the clinicians use capnography to confirm tracheal intubation. So in conclusion, I'd like to say that we should consider every intubation in the critically ill patients as a high-risk procedure, seeing this high rate of complications from smaller series and now confirmed in a large study, the INTUBE study. And various methods of these complications can be reduced by implementing measures to improve the first pass success, like the operator experience. The training is very important, video laryngoscopy, perhaps bougies, stylets, optimizing the peri-intubation oxygenation further because the complications are still 9%, and definitely hemodynamic optimization. And I cannot overemphasize the importance of using capnography. And as I mentioned, hemodynamic complications are the highest, and there may be fluids don't seem to be working, and there may be a role for the early use of vasopressors. However, this needs to be studied prospectively. We are currently doing a randomized controlled trial comparing the early use of vasopressors with the early use of fluid prior to tracheal intubation in the intensive care unit. Thank you very much for your attention. Wherever you are listening to me, do take care and stay safe.
Thank you. Thank you very much, Sheila. Thank you for your brilliant presentation. As we discussed previously, it would be very interesting to see what impact your lecture had in our audience. So we are going to repeat the poll questions that we did at the very beginning. So question number 3. What are the factors that make airway management a high-risk procedure in critically ill patients, thereby increasing the risk of complications? So please, we are going to put on the screen that poll so you can again answer, and we will see if we have some changes in some of the audience members. So here it is. Again, what takes it a high-risk procedure? So it disappeared. No worries, we'll try to put it up again. Otherwise, we'll move on to another poll question. Let's see if we can start it. Put the poll question number 3. Okay. It's not possible. Don't worry. So we'll move on.
No problem, Anna, because they got it right even before I started.
Exactly, 80% got it right. The
so
problem
of all the 3 things, it's the complex environment, it's the critical illness, and also the third point that's already there. So it's a combination of all the above. The correct answer is D.
Exactly. So that was the correct answer to our audience. And we will put now the question number 4 of our poll that was basically about what is a physiologically difficult airway. And that was very interesting, the results we got. So let's see what our audience answers this time. So what is a physiologically different airway? So think about Sheila's presentation and let's try to get the right answer. So 1 minute, please, to vote. So while we wait for the poll answers regarding the previous question, indeed, it was good to see that pretty much the vast majority got right the other poll question, right, Sheila?
Yeah.
Okay, I think we're going to get our results now. So what is a physiologically difficult airway? Let's see if we can show up the results this time.
I think the options were a little complex. So the correct answer is C. Okay, so if you can read that out, Anna, that would be great.
Yes, so what is a physiological difficult airway? It's a severe physiological derangement in the patient that increase the risk of cardiovascular collapse and other complications during airway management. So that was the answer to that question. And before
anyway, more people opted for this compared to the previous time. And I think this is really the crux because it's a physiologically difficult airway that increases the risk of complications in these patients.
Indeed, Sheila. Our audience, before we go to because Max is being flooded with tons of questions, our audience is very curious about the second poll question that took place during Vincenzo's lecture. So Paula, can you show
we
us
need to
our
see the
results?
results about that question. I will remind you. We were asking the audience which measures could be taken to improve the outcome in these patients. So here's the result. The options were the best pre-oxygenation strategy that got 38% of the answers, video laryngoscopy 21, and the one that got most of the answers was identification of the best method for peri-intubation hemodynamic optimization. Well, Vincenzo, what do you think about the answers?
Well, it's the right answer. Probably, yes. We, as also Sheila said, we are now quite good at pre-oxygenate our patients. For video laryngoscopy in critical care patients, there is and this is an off topic. The evidence is not conclusive to suggest the systematic use of video laryngoscopy in all patients. Many variables may play a role, including the operator experience and expertise on the use of video laryngoscopy. And it has already pointed out probably the COVID-19 with the widespread use of video laryngoscopy will increase the experience and availability of video laryngoscopy in our ICUs. And probably if we do a randomized trial on video laryngoscopy use today after the COVID pandemic, probably we get different results. And so, yes, according to the study, probably the more urgent answer to provide is to identify the best method to optimize peri-intubation hemodynamics. As Sheila already showed, fluids are not effective. Probably the pathophysiology of intubation is different. Fluids probably provide only a transient sense of confidence. We only transiently increase the systolic blood pressure, but probably the induction agents, the positive pressure ventilation needs a different intervention that is probably the early use of vasopressors. And the systematic adoption of awake intubation. Well, guidelines suggest the use of awake intubation in the very critically patients, severely hypoxic and hemodynamically unstable patient due to the high risk of cardiac arrest following intubation. However, this is a really difficult intubation to perform. So the systematic adoption of awake intubation is not, let's say, recommended because it is a procedure that requires a really skilled operator, but should be considered in order to avoid the detrimental effect of positive pressure ventilation and induction agents, because in that case, you will keep the spontaneous breathing patients and you will avoid the induction agents And in that patient, probably also ketamine, midazolam, and other drugs may play a role on the hemodynamics consequences, and in expert hands should be considered.
Yeah, Vincenzo, if I may add this, there is just to address what you said, a lot of people say, oh, so because of hemodynamic collapse, why don't we just do awake intubations? And that's really challenging in critically ill patients. But one of the things that we could use is ketamine in lower doses, sedative doses, what Scott Weingart calls a delayed sequence intubation. So you could use sedative doses of ketamine. And often when these patients are very agitated, we just try to knock them off and try to intubate them very quickly. We don't pre-oxygenate them well. But if you do a delayed sequence intubation, you give sedative doses of ketamine, you can actually pre-oxygenate these agitated patients, and they're agitated because they're hypoxic. So they actually need to be pre-oxygenated, but you're not able to do that. So you do a delayed sequence intubation, you give ketamine to these patients, pre-oxygenate them well. Some of them may not even need intubation, or you may proceed to do a rapid sequence intubation. So this is one of the ways of avoiding that awake tracheal intubation, and doing a rapid sequence, and also using a drug that's more cardiostable.
Thank you, Sheila. I think, we are really submerged with questions. We are running out of time, but I believe that many of these questions have been already answered more or less by the two lectures and by these final comments. Before leaving the last words for our wonderful chairs, so Paul and Anna, I just have a very short comment. We didn't have questions on this, despite both Vincenzo and Sheila addressed this point. We have many of these protocols. We know about capnography, we know about the driver study, we have the Stiletto study now. But interestingly, 50% of cases had protocols and used them. 50% of ICUs, they had protocols, but they did not use it. So I think that this is probably the area where we need to work more. So please, Paola and Anna, your last words. I thank you, all of you, for participating personally and as president of the European Airway Management Society. I think it was really a nice webinar, and I invite you to join the society so that you can enter the members area, follow this the recording of these webinars offline, and consider being part of this community where all this discussion can take place. Thank you again, and please, your words.
Thank you, Vincenzo and Anna.
Thank you.
And Sheila. Thank you for your engagement in preparing the webinar. And well, you not only have taught us about critical care patients, but also how to run a study across the 5 continents. So now, Anna, let's move to you. Would you like to round up?
Yes, thank you again. All your questions, we'll try to address them in the EM's journal section, so of terms of anesthesia and critical care. So please type in your questions, we'll try to address them. And regarding our take-home messages from our speakers, so Vincenzo, he's basically said that the major perintubation adverse events occur frequently in critically ill patients. Hemodynamic collapse is the leading complication following tracheal intubation, and hemodynamic optimization before tracheal intubation may reduce morbid mortality in these patients. Complications during tracheal intubation can be reduced by implementing measures to improve first pass success, optimizing peri-intubation oxygenation and hemodynamics, and the use of capnography. Again, fluid loading before tracheal intubation has not been shown to reduce the incidence of cardiovascular collapse. And here we have our next EMS webinar. It will be taking place on the 22nd of July. It will be about advances in pediatric airway management with this fantastic panel. Again, thank you for joining our webinar. We hope to see you next time. And remember, if you wish your certificates of attendance, please send an email to our secretariat Those certificates are free of charge for EMS members. If you are a non-EMS member, you have to pay the fee of 30 euros to have that certificate. So basically, after our president's words and our words, I don't know what you're waiting to become an ES member. Saying that, please stay safe and well, and see you next time. Take good care.
Thank you. Bye.
Thank you. Bye.
Thank you.